I think Nick's talk was a nice segue into this, my talk, because you might say, what does the nose have anything to do with the brain and delivering drugs? And I promise we'll get around to that. And I also just want to thank everybody for taking the time to come today. So I do want to acknowledge that the research we're going to be talking about is done by myself as well as my collaborators, both at Boston University and Northeastern University. So what we're going to talk about is a structure called the blood-brain barrier, which is a barrier that prevents drugs from getting into the brain. I'm going to talk about how current strategies are used to try to deliver drugs to the brain. And then we'll bring it around to talk about some of the aspects of the nose that we can actually leverage in order to deliver drugs to the brain and penetrate the blood-brain barrier, and then talk about some of the future steps. So let's talk about why is there a need to go through the blood-brain barrier. Well, the blood-brain barrier is essentially a physical barrier that lives in the blood vessels around the brain, as well as in one of the linings of the brain called the arachnoid membrane. And this barrier prevents 98% of any pharmaceutical agent, any therapy that you might want to deliver to treat a patient with a disease of the brain or central nervous system from getting in if you give it, for example, via a pill or even via an injection. Now, why is this a problem? Well, neurodegenerative disease, among other central nervous system diseases, is a huge problem in the healthcare system. Alzheimer's disease alone accounts for about 35.6 million patients currently, but is rapidly expanding and will be at about 115 million patients by 2050. And this will cost the US healthcare system over $1 trillion a year. Similarly, Parkinson's disease, which is the second most common disease, accounts for about 500,000 patients and $23 billion a year. Now, the unfortunate thing is that there are drugs that are already available that could theoretically treat not just these diseases like Parkinson's and Alzheimer's, but other diseases of the central nervous system. Now, these are just the fancy names of these drugs, and this is what's called the molecular weight. So these are the size of the drugs. And when you see KDA, what that means is kilodaltons. And that's essentially just a measure of the size. And what I want to stress is that, for example, this is 73,000 daltons. The size of a drug that can get into the brain is 500 daltons. So you can see we are way over as far as size, as far as what the size of a drug that can get through relative to the drugs that are currently available that could treat these diseases. There's just no way to get them into the brain. Now, this is a very busy slide, and there's not going to be a quiz at the end of this, but I just want to make the point. This is a cross-section of the brain, and for the two most common diseases, Alzheimer's disease and Parkinson's disease, these are the areas of the brain that we want to target with these drugs in order to not just prevent the progression of the disease, but actually potentially cure patients of the disease. And we'll get back to this picture later. So Parkinson's disease is a good example of where people have already tried to use some of these very large drugs to treat the disease. So GDNF stands for something called glial-derived neurotrophic factor. It's a very long name, but the important thing is that it's 35 kilodaltons, so that's 70 times larger than what can get through the blood-brain barrier. So in order to deliver these drugs, these clinical trials have literally had to place a catheter directly into the brain through the top of the head and pump the drug into the brain or into an area called the putamen, which is near that structure that I was showing before, that target for the treatment of Parkinson's disease. So just going more broadly into strategies that have been used to try to deliver drugs to the brain, what I've mentioned already are these invasive strategies. So essentially you drill a hole through the head, you insert a long needle or a long catheter directly into the brain, you then have to tunnel a catheter under the skin and connect it to a pump that lives under the skin in order to deliver these drugs long term. Now there are other methods that are non-invasive, and these are methods where you can actually take a single drug and manipulate it and couple it to other proteins and fool the body into taking it up into the brain. But you can only do this on a drug-by-drug basis, and this is incredibly expensive to do. And so you might imagine that as I showed you just a brief list of the types of diseases that need to be treated, you can't do this for every single disease. The costs are just become astronomical. The other major problem, as you might imagine, by drilling a hole into the brain, is that essentially every single patient that gets this gets swelling around that catheter tip in the brain. That's called vasogenic edema. The other thing that you want to bear in mind is that anytime you're putting a foreign body into the brain or tunneling a foreign body like this long catheter under the skin, you have a risk of infection, and you have a risk of that catheter being moved. And so in fact, in the studies that have used this, 40% of patients need that catheter either replaced or reimplanted, or it gets infected. And so again, you start to consider the hundreds of millions of patients that need these types of drugs, and you can see these are not really feasible methods to deliver this long term. So what would be the ideal strategy to deliver drugs to the brain to bypass this blood-brain barrier? Well, the first is it would be a platform technology. What that means is basically it's not something you can use for one drug, it's something you can use for multiple drugs. Because we already know that multiple drugs exist for this. But also, and I think maybe even more importantly, it would be an enabling technology. So what that means is that right now pharmaceutical companies aren't really interested in developing and doing the research into developing drugs for these types of diseases because they know they can't get it into the brain even if the drug worked. But if there was a way to reliably do this, this would stimulate a whole, additional research and development into these drugs, not just for Parkinson's and Alzheimer's, but for a range of CNS, central nervous system diseases. And then finally, practically speaking, it has to be a scalable technology. It has to be safe. It has to be cost-effective, because we all know that we live in a healthcare environment where cost is very important. And it has to be something that can be done worldwide, not just at highly specialized centers, because these patients are global, they're in first world countries, and they're in third world countries. So we think that we've hit upon something that may be a strategy that meets a lot of these criteria. And what we've done is essentially said, well, can we create a screen door in the blood-brain barrier that we can use long-term to deliver drugs through there? So the benefits of the technique that I'll describe is that it's non-specific and it's semi-permeable. So that just basically means it can be used for many drugs, and it doesn't let everything through, but it lets a lot of drugs through, particularly drugs up to the sizes that we've been discussing. It's permanent, and it has its own active immune function, which means it fights infection. So unlike the catheters that are placed that have to be reimplanted and get clogged and so forth and cause infection, the method we're talking about actually fights infection on its own. And again, it uses no foreign materials. The technique that we're going to describe is minimally invasive, so there's no external incisions involved at all. It's half the cost of the methods I've described, and it's about 10 times safer. So what is that technology? And it's something we call mucosal grafting. So now we're going to bring this back to sort of the nasal and sinus realm. So the other thing that we do after we've sort of gone through the sinuses is that we can actually go up through the bone between the sinuses and the brain and take out tumors of the brain itself. And as Dr. Busaba was mentioning, there's been a whole range of technologies that have progressively allowed us to do this and get more and more aggressive at doing this. But as you might imagine, in order to get from the nostril into the brain, we have to create a pretty big hole in the brain. And that's a problem because the brain is surrounded by a sac of fluid called cerebrospinal fluid. So if we make a big hole in the brain, we have to patch that hole. And we've spent, both myself and my colleagues have spent about 5 to 10 years designing better and better ways to patch that hole. And now we have methods where we can patch the hole where the complications are less than 2%. Patients don't get infections, they don't get leaks long term, and the patch is permanent. So what are we really doing here? So just this is a cross-section. So here's the brain, this is the top of the nose. You have this lining, that's the arachnoid that we talked about that has that blood-brain barrier. This is the bone that Dr. Busaba mentioned between the nose and the brain. And then this is what we call the mucosa, or the lining of the nose. So to get a tumor out of the brain, we have to make a big hole. We have to go through all of these layers. And most importantly, we remove the arachnoid membrane, that blood-brain barrier. So now we have a hole between the brain and the nose where you could theoretically deliver drugs. But obviously we can't leave a hole there. So what do? We replace it with nasal mucosa. Now it turns out that the nasal mucosa is 1,000 times more permeable to drugs than the blood-brain barrier. So the concept is, well, if it's so permeable, can we use that mucosa to actually deliberately create this hole, repair it, and then use that to deliver these drugs to the brain? So just another way of looking at it, this is an illustration. This is a cross-section of the brain. This would be where the front of the nose is. This is the frontal sinus, and this is that sphenoid sinus. That's actually where the infection that Dr. Busaba showed you before. So this is essentially the position that we would put the graft in, and this is something we do clinically on a daily to weekly basis. So we have many, many patients walking around with these healed grafts in place as we speak. So what do? Well, you put a drug in the nose, you deliver it through the graft, and you get it into the brain. Now I mentioned I was going to come back to this picture before, and again, these are the areas for Parkinson's disease and Alzheimer's disease that we would want to target with these drugs. Well, it turns out this part of the brain and this part of the brain are exactly the same. So essentially, by doing this graft, we're delivering drugs exactly to the targets for the two most prevalent neurodegenerative diseases that are known to mankind. So it's an interesting concept, but does it work? Can we prove our hypothesis? Well, whenever we have a hypothesis like this, we have to start with an animal model. And so we developed a mouse model of this. This was back in 2013 that we published in the journal PLOS ONE. And so here what we did was we created a mucosal graft over the skull, just like we would inside the nose of a human, and we delivered drugs through it. And so what you're seeing here is a cross-section of the brain, and this is fluorescence. And so the drug that we deliver fluoresces, and if it's getting into the brain, you're going to see that fluorescence on the image. And so this is what we call a positive control. So if we just make a hole in the brain and deliver the drug and don't put a graft on, don't do anything, this is the maximum amount of drug you can expect to see that gets into the brain. This is a negative control, so if we make the hole in the mouse skull, but we don't remove that lining of the brain, we don't remove that blood-brain barrier, you see nothing gets through. So this is just showing that the mouse has the same type of blood-brain barrier that we do as humans. So then we said, okay, well, why don't we start putting drugs through? So we started with something that's 20 kilodaltons, so 40 times the size of what can get through the blood-brain barrier. And you can see very robust uptake in the brain. We went up to 80 times what can get through the blood-brain barrier. Again, significant uptake in the brain. So then we said, well, let's really push the envelope here. Let's go 1,000 times the size of what can get through the blood-brain barrier. And again, relative to the control, you're still seeing drugs that get into the brain. And remember that we talked about the GDNF, that molecule that was used to treat Parkinson's disease, is 35 kilodaltons, right between these two numbers here, where we can prove that we can get drugs into the brain. So this was great, and we actually got a lot of nice press, and the PR folks at the Mass Center did a great job getting this out to the lay press. And you know, this was great, but really all this showed was a proof of concept. This just showed that we could get a fluorescent molecule into the brain, but does that have any therapeutic implications? Meaning, does this mean that we can actually treat a disease using this technique? And so then we took the next obvious step and we said, okay, well let's take that mouse model, let's give it a disease of interest, and then let's treat it. So we developed a mouse model of Parkinson's disease, and we treated it with that same molecule that's been used in clinical studies, GDNF. Again, it's that 35 kilodalton molecule. Now this was just published about 2 weeks ago in the journal Neurosurgery. And again, this has gotten a lot of very nice press where we have demonstrated this model. And there's a lot of data that shows this, but basically the long and the short of it is that we demonstrated that we can actually prevent the mouse from developing Parkinson's disease as effectively as directly injecting the drug into the brain by using this technique. Just to show you pictorially here, this is again another cross-section of the brain. This is the mouse striatum. So this is just one of those target organs that we treat for Parkinson's disease. And this is what it's supposed to look like when we stain it, nice and bright. When we induce Parkinson's disease, this is what you see. You see a loss of all that staining. And then here, this is that gold standard. So we inject the mouse brain with the GDNF, and we see almost a complete regain of function relative to the normal side. This is the transmucosal delivery. So again, delivering the drug through the mucosa, you see we're almost as good as direct injection. Now, this is what we call histology. Now, this is slightly less than what we see with injection, but when we do our behavioral studies, which is what we would see clinically in a patient with Parkinson's disease, we actually do as good, if not better. And so there's a slight difference between this picture and the behavior, but suffice it to say, we have essentially prevented this mouse from developing Parkinson's disease. So where do we go from here? Well, the first thing is that now we have the technique to deliver the drug through the graft into the brain. And I like to think about this as like, imagine an IV that you get into your arm in an IV pump. So we have the IV needle. We can get the drug through the blood-brain barrier into the brain. But the problem is, if you want to deliver a drug into the nose, the most obvious way is, well, just spray it in the nose. And you can certainly do that, but there's a couple of problems with that practically. The first one is that patients don't like to do that, and as you might imagine, an elderly population with Parkinson's disease or Alzheimer's disease might have a very difficult time remembering on a daily basis to spray that drug in the nose. The other issue is, even if you, at the best of circumstances, you're going to have a lot of variability in how much drug actually gets into the brain. And just like when you take a pill, or if you're putting an IV and you're infusing a drug, you really want to have a tight control of exactly how much drug gets into the brain on an hour-by-hour basis. And so what we've done is we've started to develop these drug-eluting polymers. So these are essentially compounds that we can implant in the nose that we know exactly how long it takes for these drugs to come out of that compound, and we can control that over weeks to months. And so this is essentially the equivalent of the IV pump. So now we have the IV needle, and now we have the IV pump in the form of these polymers which we're developing. So where does this go kind of into the future? How do we get this into patients? And this, is really where I think the funding issues come into play. So right now we're working in small animals, and we're looking at exactly how the drugs get in, how long it takes, what the exact dosing we require is. Based on that, we're going to move quickly into large animal studies, because now what we want to do is actually put the graft inside the nose of an animal and deliver drugs that way to more closely approximate what we do in humans. Finally, and very quickly, within a few years, we're already doing these same type of what we call pharmacokinetic studies in actual humans who have already had this graft done for other reasons. So we're delivering the drug, and we're seeing exactly what dose they need and exactly where the drug goes when we do it. And then finally, within 10 years, we think we'll be in clinical trials, hopefully either in Parkinson's or Alzheimer's disease. Because remember, the nice thing about this entire research paradigm is we don't have to prove that the surgery works. We know the surgery works, we do it all the time. We just need to show that we can get drugs through in patients, and really more to the point, we just need to tune those drugs to know exactly how much to put in, what the dose needs to be, and how long we need to dose them for. So in summary, there's an enormous unmet need to treat neurodegenerative diseases, which account for a huge component of the global disease burden, because 98% of all those potential drugs just cannot get through the blood-brain barrier. Currently, there's literally no feasible, scalable method to bypass the blood-brain barrier, as we discussed. And we also mentioned that the ways that people are trying it now have over a 40% complication rate. In contrast, our grafting technique is cheap, it's scalable, it can be done globally, and it's already been in clinical use for over a decade. So essentially, this is the first technology that's ever been described that can permanently bypass the blood-brain barrier using the patient's own tissues. And we do think that this is both an enabling platform technology that will allow not just current drugs to be used, but will stimulate research into new drugs. So thank you very much.